right, good afternoon, everyone. Welcome. We're very excited to have you join us today for our webinar that is really kind of connected to the launch of a new resource that's been developed between the team at Sinai Health and the team at UHN. But I think also we're very blessed that in the production of this resource, we engaged a number of people living with heart failure, caregivers, patients, who really shared their perspectives about their journey. So really want this to be a discussion, a conversation. We're really grateful that several people sent in questions ahead of time. So our speakers are really going to make an effort to cover that territory. So I'm welcoming you. My name is Anne Simov. So I'm a staff scientist at UHN, and I'm the research director in the heart function program within the Ted Rogers Center for Heart Research. We're going to introduce you to our wonderful crew that will be speaking. And ahead of time, just really want to say, please mute your mics. Please, when you have a question, put it in the chat. We're going to focus first on the chat questions. And then if there's some time, we'll open up the floor to a little bit more conversation. But just really want to make sure that we respect those who sent questions in and give time and attention to answering their needs. So without further ado, I'll kind of kick us off and send us over to Leah Stanberg, who's really been my partner in crime and goodness and wonder throughout the development of this resource. And she will really lead us through and introduce our other speakers. So Leah.
Great, thank you so much. Welcome everybody. It's an absolute pleasure to be here and sort of meet you all virtually and to be here to answer questions. Can I get the next slide, please? Terrific. So here are your speakers today. Aaron is he's on the webinar. He's a person with lived experience, and we're going to hear from him. Kayla Wolofsky is a colleague of mine. She's a physician at UHN in both internal medicine and as well in palliative care. And I'm a physician at Mount Sinai Hospital. I'm a family physician, and I also work in palliative care. And we are so happy to be presenting this brochure. Can I have the next slide? So basic, common ground rules for, sharing experience and talking together. I think everybody probably knows all of these. So let's move on to the next slide. So I'm going to just give you a little of an introduction about why we put this together. It's a sort of a second version of an earlier document. And then you're going to hear after me from Aaron and then from Kayla, and we'll go in that order. Can I have the next slide? So why did we create and recreate this guide? Really, we wanted to give patients and their loved ones, their caregivers, a way to have access to general information about the heart and about heart failure in a way that can help people start to understand more about what's happening when somebody is experiencing heart failure. We wanted to give people the beginning of ways to start to help their loved ones, their family members, their care recipients, if they're having symptoms or questions, just a way in to support. Another thing that I think this booklet can help is just to start to give people language that you can then use when you do want to talk to your healthcare team. Bring the booklet with you. It gives you just yeah, I see Aaron's nodding. So that's great. Sometimes this can be really intimidating. You want to talk about your shortness of breath, or you want to talk about your fatigue, and you're like, is this really okay to talk about? And we want this booklet to give you some power to say, look, it's in this booklet, I want to talk about it. So give you a little bit of control. And also to give the best suggestions that we have at a basic level for helping with some of the symptoms and the issues. really to normalize it as well for people. Can I have the next slide? So I don't want to take too much time because you've got access to the booklet, but I just wanted to kind of give you the heads up about what are the areas that we thought would be important to cover. And the first section really talks more about what is heart failure? Why are you feeling, or your care recipient, your family member, why are they feeling the way that they're feeling? What's going on with the heart that's causing these things? And then we have a section that starts to introduce the idea of what we do know for some people about what can happen in the future with heart failure, so that it's something that you can start to learn about, get prepared for. It isn't the case for everybody, but I think many people want to have more information rather than less. So it starts to give you some of that education. And then the bulk of it really is a section on what are the different symptoms people can have with advanced heart failure, and what are some of the techniques for managing those symptoms. And I know we're also going to hear from Aaron with his lived experience of what he's found helpful and maybe less helpful. And then the last section is really about what are the other supports? What are ways to get extra support to help you through this, and to live well and comfortably and with as much support as possible? And there's sort of a bunch of different subsections. One is about making sure that everybody's monitoring their symptoms as well as possible and has the best access to making sure that you're getting your symptoms well controlled. For example, measuring your weight on a regular basis and knowing who to call. So that's really important that you know that well, and really, again, empowering you to know that you can reach out. Another subject, which we'll talk a little bit about today, I'll actually introduce you to it a little bit, is something called advanced care planning, which, if I had my druthers, I would change that phrase. But anyway, I don't. And so I'm going to spend a few minutes just talking about what do we mean by that. And then some resources around what else can you do to help build supports around you. And in the booklet, we talk about the role of palliative care. And you probably heard me introduce myself as a palliative care clinician. And I want to reassure everybody that the role of palliative care in patients with advanced heart failure is one of an extra layer of support. It's not what palliative care used to be, which is at the very end of life for people who are dying. We've recognized, and cardiology has recognized, that there's a role to talk about symptoms and to help with symptoms as you're living with your heart failure and doing well. And it's not about end of life care. It's about wrapping an extra layer of care to make sure that you're as well informed and as feeling as well as possible throughout your illness. So I don't want people to get worried about why is there a palliative care doctor or two actually on this talk. So that's kind of the structure of the booklet, and I hope that explains that for folks. I'll get the next slide, please. Okay, so that's that slide was in the wrong place. Sorry about that. So what do we mean? I'm just going to kind of launch into this topic about what do we mean about advanced care planning, because you'll see, booklets around and you'll see, everyone should be doing advanced care planning. What do we really mean? And I like the word preparing yourself, or thinking about preparing yourself and preparing your caregivers for anything that could happen in the future. And in fact, we do say that everybody has a role to think about how to be best prepared for the future, whether that's for yourself, or maybe you're the caregiver for somebody else in your life, or maybe you're somebody's sibling. And it's important that we are all thinking about what might happen, what are the kinds of decisions that might need to be made. And I want to be really clear, we're not talking in advanced care planning about making medical decisions in advance. That's not what advanced care planning is. It doesn't mean that you're going to know that you do want something or you don't want something sometime in the future. It's that you know that there are decisions that may come in the future, and that you and what we call your substitute decision maker has some awareness of what those decisions might look like. And so that if at a time in the future decision making needs to happen, it's not the first time you've heard about, say, dialysis, or it's not the first time that you've heard about other treatments that it's good if we've had some time to kind of learn about them and think about them. So really, it comes down to sort of these three components. And the first is learning more about the illness and what the future might hold. What are the kinds of decisions that people might face in the future who have heart failure? And whether that's a year from now or 10 years from now, there are people who find it more helpful to be aware and to be learning about them. And not everybody does. So this isn't mandatory, but for some people, it can be helpful. The second is learning who does the law say is your substitute decision maker. In Ontario, actually, everybody has an automatic substitute decision maker. The law says who that person is. And so if you were sick one day and a decision needed to be made about your care, your health, the doctors actually know there's an automatic decision maker. And for most people, that's your next of kin. That's the person closest to you in your family. And there's actually a hierarchy, which I'll show you how to see that in just a moment. That's important to know because for many people, the next of kin is the right person to be the decision maker for them, whether that's your spouse or your child. But there will be some people for whom that's not the right person, but it's actually the automatic substitute decision maker. Okay, so the reason to know about this is not so much if you're comfortable with your automatic substitute decision maker, that's going to happen. It's if you'd rather appoint somebody else. So that's the important part of this. For some people, they'll say, my next of kin, I don't have a partner, I'm not married, and I don't have any children, so it's my sister. My sister would be my substitute decision maker, and she's your automatic substitute decision maker. You don't have to do anything, but maybe you would say, you know what, I don't think my sister would be comfortable making decisions for me. I don't want to put that on her. I would rather it be my cousin. In that case, we all need to fill out, or you would need to fill out what's called a power of attorney document. And that's the legal document you would need if you want to change the automatic substitute decision maker to somebody else. Sorry, I didn't actually mean to go into this much detail about it, but I think this is like the most important thing about advanced care planning. That document is easily found on the website. You can just, you don't need a lawyer. That's something you can do. So I'm just going to stop there because that's the main reason to sort of think about substitute decision makers. And if there's questions about it, I'm happy to go into more detail. So those are the first two important parts about what do we mean by advanced care planning. Understanding what may happen in the future and what different decisions may come up, learning who's your automatic decision maker and figuring out if that's the right person, and then just talking together with that person so that you are both informed and have had opportunities to talk about what matters to you, how you like to make decisions in case there's a time when they have to make a decision for you. Okay, can I have the next slide? That is all better explained, and I'm not going to go to the website because I've actually gone through a lot of it in person. This website, Advanced Care Planning Ontario, is a patient or person public, that's the right word, a public-facing website that actually walks you through all of this process. It will tell you who your automatic substitute decision maker is. It'll help you figure that out. It'll give you questions to help you and your automatic substitute decision maker talk together. And so that's really the one website I would say you need to help you go through all of this. And I'm going to pause there and happy to answer questions later on if they come up. Next slide. So that's what I have to say. And I want to introduce Aaron Ablona. I'm really excited to hear him speak. And thank you so much.
Sure. Hopefully you guys can hear me okay. But my name is Aaron Ablona. I've been a heart failure and stroke patient since 2015. Along the way, I've received a quadruple bypass, AICD implanted. In 2018, I had my right leg amputated below the knee. Fast forward to last year, I joined a Transform HF research event, and I've been in contact with the Transform HF and the Heart Hub ever since. So next slide, please. So like Dr. Steinberg was talking about, I think an important piece of advice would be to learn as much as you can about your unique diagnosis. Just within heart failure alone, there are separate different heart failures. I myself have reduced ejection fraction, so you should learn about your specific heart failure, and then there's different classes as well. So make sure you're educated as to which diagnosis you have, and as well as comorbidities. So you'll figure out there's a relationship between heart failure, the heart and the brain, so heart failure and stroke, and diabetes as well. So it's important to kind of learn and to know what you're at risk for too, because that can affect your treatment plan. And then moving on, so you should also learn about the medications, because on heart failure you'll probably be prescribed medications. So you're gonna want to learn about the pills that you're kind of putting into your body. And like over time, I've learned that with heart failure, with reduced ejection fraction, there's four pillars: RD, beta blockers, MRA, SGLT2I, I think. Okay, so learn about the things that you're putting into your body. Learn about which meds are taken at certain times, why they're taken at certain times. Why you take it with food, why you take it on an empty stomach. And you can discuss this with your cardiologist or even your pharmacist. And I would suggest, learning about your pharmacy, learning your pharmacy details, the address, contact information, getting to know the pharmacist, so they can kind of help you with that medication uh knowledge too. And you'll find that doctors are always adjusting doses and contacting between each other and the pharmacist. So you want to make sure there's a you have a good relationship between all parties. And then like doctors are also always frequently asking, what blood thinners are you on? So you want to be aware, and you want to learn like which what are my blood thinners, what are my blood pressure medications. So learning about the medications that you're putting into your body are very important. And then physical exercise is also kind of important. So, you want to start off slow and steady, and you want to be attentive to pain and fatigue as well. So when I got out of my diagnosis, I started in stroke rehab. So we started with, and I had my leg issues, so I started on the bed. So I started with bed exercises, bed exercises and stretching, and then eventually it started to sitting exercises. So you start slow, and then steadily move up, and then sitting eventually got up on my feet, and then I don't need to run a marathon, but I can walk within the hallways in my house, and then slowly increase, walk outside, walk to the corner, and then you'll slowly learn how much you can tolerate. As and maybe when you're walking in your block, you'll learn like, oh, if I stop here, there's a bench here, I can rest here. So you're gonna learn a lot about what you can tolerate, and sometimes it might just be, you can only do sitting exercises, and that's fine. But I would just suggest, better is some is better than none. So get up, and even if you're just lying down and just doing better exercises and stretching, some is better than none. And then as you're working out, like I said, you'll learn what works for you, what to avoid, situations to avoid. I don't like this part of the neighborhood. I don't like this exercise. This exercise is too much. So you'll adjust as you go along. All right, next slide, please. And so as you're going along, you're gonna try to and change and adjust your routines. And I would suggest like starting right in the middle, right at the start of the day. So right when you get up, sit at the side of your bed and just take a deep breath. Kind of, you want to ground yourself. You'll take a deep breath. Obviously, if you have to go to the washroom, you can kind of rush, but you kind of want to clear your head, take a deep breath, and then get up, and then uh, start your day off. And then if you have a morning routine like making your bed, waking the kids up, starting breakfast, you're gonna want to try and add getting on the scale, weighing yourself, and checking your blood pressure as well to the morning routine. You want to kind of keep doing that and doing that and doing that. The more you do it, the more it'll be second nature. And you're going to want to track your symptoms to track the weight and the blood pressure. Either you could keep it in some people might have access to Medley, which is an app that tracks your blood pressure and weight. But for me, I just write it down. I write it down in a notebook, and then I can see like from the top number to the bottom number if there was a big change between each day. If there was, more than a 2 pound change, you usually have to take a diuretic or a water pill. So, it's important to get that into your routine. Keep checking your weight, keep checking your blood pressure, and keep track of those numbers. And in case and just in any symptoms that you may suffer. If you're feeling dizzy one day, if you're feeling lightheaded, Maybe don't exercise that day, just take it easy, and then just keep a track of that, and then bring that up to your doctor as you go along. And then you'll probably be asked to be put on fluid restrictions as well. And this is kind of what'll help with the weight the weight management. And so for usually it's about like 2 liters. And so what I find help for me was just taking like like a 1 liter bottle of Perrier, 2 of these, and then just measuring out kind of my liquid for the day. And then you want to be sure to minus the measurements for cans, other liquids like soups, because those all will add up to the liquid amount. And then you'll find that 2 liters is actually, it's kind of a lot, so uh don't be too frightened about the 2 liter limit. And then as for meals can kind of be a little bit difficult, especially when you're asked to be on low sodium, just because salt is in everything, sodium is in everything, right? So I would suggest starting off with portion control. Start with smaller portions, and then space out your meals, more smaller portion meals out of along the day. And then sometimes if you think you're hungry, you just take a sip of water, and then you'll find that maybe I was just thirsty, and then you'll be able to skip that meal just in case. But I would suggest, yeah, smaller portion meals. And then one of the more difficult things about the low sodium is eating out, right? Eating out, dining out with friends or dining at a restaurant. So there I would suggest, again, repetition and repeating. And this is where, like, when you go to a restaurant and you suggest when people the waiter asks, do you have allergies, should I let the chef know? Well, this is where you can also know, I also need low sodium, or can I have my dish with no salt? The restaurants are there to serve you, so they should be able to accommodate you. And yeah, if you're uncomfortable about that, then you can ask the waiter for, maybe low sodium alternatives, or yeah, or just just little salt, or just you switch the salt with another spice. Cooking at home, you have a whole spice rack of alternatives for salt, and some good standbys are lemon juice or zest, or just chop up some roast garlic and onions, and just keep that in the fridge. That's a good like little garnish as a replacement for salt. But the more you repeat, no salt, less salt, less salt, the more people around you will kind of get the message. And then hopefully your friends and your family will kind of take over. When you go to parties, oh, Aaron's coming, and he has low sodium needs, so maybe let's make a separate portion for him. And if that's too difficult for your friends, then maybe just bring your own food, bring your own portion of low sodium food. But you want to be advocating for yourself. You want to kind of get your friends to and family to repeat, no salt, no salt, no salt. That way, you'll be more comfortable kind of explaining that situation in public. All right, next slide, please. And finally, you're gonna want to keep your social circle. I was kind of lucky when I got my diagnosis, because I received it in a hospital bed, and so my friends and family came to me, and so they kind of saw me in my situation, and so I tried to keep those connections solid, those family and friends connections solid, because those are the people who will also reinforce your no salt claims. Those are the people who will be cooking food for you. Those are the ones who will be attentive to oh, Aaron's coming over to our party, let's make sure he has a place to sit when he comes, or a place to lie down just to rest. So make sure you have keep in touch with your social circle, and a spiritual advisor like a priest, if you're comfortable with that. And then you also want to keep constant communication with your healthcare team. Doctors, nurses, therapists, and your caregivers, and you want to think of it like a team. It's a team, everybody's there, and we're all there to help you, the patient. So right. So you want to keep constant communication, make sure you're letting people know how you are, letting them know about symptoms like that. So constant communication. And just online, like now, like this is the golden age of connecting through Zoom. So there are many online organizations like Heart Life, Heart and Stroke, Global Heart Hub, Even through Eventbrite alone, I saw Cardiomyopathy UK has advanced heart failure meetings for free, so that you can join. So there are online resources, online meetings for you to access and connect. And I'm part of a heart failure group. But we have weekly talks, and we don't even talk about heart failure sometimes. We just chat. We just say how each other is doing. So you'll find that they're building the community. You're linked with one kind of like a central theme, but you'll find the sense of community. Everybody's welcoming, and you'll find that the theme isn't really the central thing. It's the sense of like getting to know each other, getting to see how everybody's doing. So you want to keep constant communication with your friends, family, doctors, your healthcare team. Find a community of patients with lived experience or caregivers online. Constant communication. That's what I would suggest. And all these things can kind of help to build confidence in your treatment plan, confidence in yourself going forward. And yeah, so just ta- keep talking, and keep letting people know how you are. I think the more you kind of repeat, the more you kind of keep ingraining in your friends that your needs, and they'll kind of show empathy, and kind of return the favor. And then you'll find out feel the burden of heart failure, I guess, lessened, if you will. And yeah, that's it for me.
Thank you so much, Aaron. That was fantastic. My goodness. Um, I want to now introduce Kayla Wolofsky, who works at the General and is a colleague, and she's going to talk about some of the common symptoms. You'll find all of this in the booklet. And welcome, Kayla. Thank you so much. And you're just on mute still. There you go. Great.
Oh no, I was purposely keeping it on mute just because there's stuff going on at the hospital. Good morning, or I guess it's afternoon, everybody. Thank you so much for having me. It's such a pleasure to speak with all of you. So I am a palliative care doctor here at Toronto General Hospital, and I'm actively involved in a lot of patients with heart failure. And so I'm here today to talk to you about just some common symptoms. A lot of these are things that we can manage at home without medications, but I'm also going to give you ideas as to what your doctor might recommend. But of course, they might have a different suggestion, but this is kind of the broader picture. Next slide, please. Next slide. Thank you. So symptom burden, when we think about palliative care, many people compare palliative care to cancer. And so as kind of was like alluded to in this conversation, now palliative care is seeing a lot of patients that are not necessarily end of life, but do have a lot of symptoms. And the symptom burden in patients with heart disease is huge. And it's actually quite similar to those with advanced cancer. So some of the top major concerns have been things like fatigue, just feeling really like short of breath, some numbness, difficulty sleeping, lots of pain. So as you can see, the symptom burden for someone living with like heart failure is quite substantial. Next slide. One of the main symptoms that we kind of come across in a lot of patients with heart failure is dyspnea or difficulty breathing. This doesn't necessarily mean that their oxygen is low. So someone might be short of breath, even if their oxygen is sitting at above 90%. And that's just it's a subjective feeling of I can't breathe. And for many people, that can obviously be really distressing. This is really common. So over 50% of patients with heart disease will have this. And in terms of why this happens, the underlying cause, like the list is kind of ongoing, and it's never just one thing. It's usually multiple things. I'd say the biggest things are they might have fluid overload, the heart isn't functioning as well, so they're not pumping blood around as easily, and so some of that kind of fluid builds back up in your lungs. Of course, with the heart failure, you might be a little bit deconditioned. So as you can see, there's multiple reasons why one might feel quite short of breath. Next slide. How do you manage this? So at home, what can you do? The feeling of oxygen sometimes actually helps and is enough. So having windows open, having a fan is really helpful. if you're able to get an adjustable bed, because of course lying flat can be quite uncomfortable, so getting something that might be able to go up. Things like cardiac rehabilitation or chest wall vibration, which is an example of some kind of physiotherapy. You know, in patients who have heart failure, they might not necessarily need oxygen and you might not qualify for it, but some people do find having additional oxygen through the nose does help that feeling of shortness of breath. And just doing various breathing exercises. Next slide. You know, dietary changes, so this has been discussed. So things like low salt will decrease your overall like fluid kind of balance. And of course, diuresis. So this is where having Lasix and furosemide or metolazone, all these medications you're all familiar that cause kind of increased urination can be quite helpful. Some patients do well with having a bronchodilator. So many of you might have heard of like Ventolin. It kind of depends on what the underlying cause is, but this can sometimes be helpful. When someone is nearing, I don't want to say nearing the end of life, but when we know that the trajectory is within, you know, months to a few years, we start to think about opioids. I know the word opioids causes quite a bit of anxiety for many people, and the concern is addiction. And also they assume opioids means end of life or that it can cause end of life. Opioids can be really helpful with someone who has a subjective feeling of shortness of breath. You know, we use very low doses, so the chance of addiction is exceptionally low. But again, we wouldn't be using these in someone who has like many, many, many years. And so this is something that's much later on. And of course, lastly, like, of course, being short of breath can cause a lot of anxiety. So some physicians might think about something like Ativan, lorazepam, any kind of benzodiazepines. But of course, these are all various management strategies that your physicians should be talking to you about. Next slide. I know fatigue is a huge concern for many patients with heart failure. And I will be honest with you as a physician, this is really challenging to treat with a medication. Similarly, like the shortness of breath, this is caused by many different factors. I think the shortness of breath, having to work harder to breathe, causes like significant fatigue. It's almost like running a marathon, right? Your lungs are running a marathon sometimes. You might be anemic, so you might have a low blood count. I know many people feel that they can't do as much because of their heart failure, so that can lead to mood disorders such as depression or anxiety and an overall poor quality of life. And so they have physical and social limitations, which is really hard. I do want to show you that there's not really a correlation between how severe the heart failure is and necessarily how fatigued you are. Next slide, please. You know, in terms of management strategies, I tried to highlight the ones that I really feel are the most important. And the truth is, there's very few oral medications that we can give you that are going to improve the fatigue. This is going to be a lot of, you know, you as caregivers, you as patients, kind of actively just recognizing. Of course, as physicians, we need to do our best to address the underlying cause. So are you fluid overloaded? Is your blood count low? Would you benefit from an iron transfusion? Is there an underlying cause that we can reverse? The other thing that I really want to like kind of highlight is that we, you know, it's a little bit corny, but we all wake up, you know, there's different analogies here is with like, however much energy is in our cup, that's what we have when we wake up. And so you can decide how you want to spend that energy. And so some people have an event and they need to kind of save that cup for later on in the afternoon. And so therefore you really need to take it easy and rest in the morning. Some people have multiple things and they just take small sips of the cup. Just remember that when you wake up, you have a set amount of energy that you can expend. And so you need to really truly reflect on how you want to spend that energy and then kind of adjust accordingly. And I want to give you permission. I give you permission to be tired. Having a heart failure it's really hard. And so you need to give yourself permission to take a nap if that's going to essentially rejuvenate you or fill your cup up a little bit more. Other things I can highlight is adjust your diuretic scheduling. So if you're taking Lasix at 8 p.m., you're going to be waking up till 2 a.m. to pee. And that's not ideal. So talk to your doctor about seeing if you can take it earlier. You know, some people say, okay, last dose is going to be at 4 so that I can sleep. And then kind of the other major thing that I wanted to highlight is if you can, you know, sometimes people find like a wedge or a hospital bed really helpful because again, it keeps you propped up and so you have a better sleep overnight. Next slide, please. Pain is another thing that really affects people with heart failure. And again, it's really common below the knee. And a lot of this has to do with the edema that people have and essentially stretching of the skin. You have electrolyte shifts, so your potassium shifting, your sodium shifting, and a lot of those shifts can actually cause pain. And don't forget that pain doesn't necessarily just have to be a physical thing. It can be total pain. And we can be talking about things like, emotional pain, like what you're going through. For some people, it's spiritual pain, why me? What did I do? And so pain can be quite complex. And I want to recognize that it doesn't just have to be a physical attribute. Next slide, please. How do we manage pain? I'm sorry, I don't have a slide here for non-pharmacological things, but in terms of pain, I think, going back to the basics of massage, acupuncture if safe, if you're not on an anticoagulant, or things like heat. Addressing is this total pain, so seeing a spiritual care provider, or again, addressing your mental health. In terms of management strategies, pain is really challenging. As long as your liver is okay, it's a lot of people kind of don't always think that Tylenol is that helpful. I actually find it really helpful. So if your liver can tolerate it, I think talk to your doctor about just getting Tylenol and just having that on board. Things like gabapentin or pregabalin, so these are they're known as neuropathic agents, can really help with especially the fluid shifts. There are side effects to those medications, so you do have to really talk to your family doctor as well as your cardiologist before ever going on these medications. We talk about low dose opioids, but that should always be a last resort when everything else has been essentially exhausted. There's topical agents, such as capsaicin cream or topical lidocaine if it's really local. But I think as many as you know is that you really cannot be taking all NSAIDs, such as ibuprofen and Advil and naproxen. And that's just because it does actually impact your heart as well as your kidneys. Next slide, please. I think one of the last symptoms, and let me know if I'm going over time, is gastrointestinal distress. And a lot of this has to do with just significant nausea and vomiting. Some people have diarrhea. And the reason that this happens is that people who have a lot of fluid, we don't get to decide where that fluid goes. And so some of that fluid can be literally sitting in our gut and our gut wall edema, and that can cause the nausea. Some people, you're on, I can recognize you're on a lot of medications, and some of these medications can actually be quite upsetting to your stomach. And so, managing these again will always come down to seeing, do you need to be on all these medications? Of course, discuss with your cardiologist. And is there anything that we can do to kind of help these symptoms? Next slide. So for nausea, I actually find a lot of the things that we can do are best treated with non-pills. So things like peppermint products, I don't know about you, but growing up, my mom always gave me peppermint tea. Obviously, if you're on a fluid restriction, you need to take that into account. Things like ginger products, there's a lot of oral chews that are quite helpful. Some people are really sensitive to smells. The other thing I would highly recommend is just frequent small meals versus the standard 3 big meals a day, because honestly, if you have fluid in your gut, your stomach's kind of compressed, right? So you don't want those 3 big meals. So just frequent meals throughout the day is just as good. Someone once taught me just putting topical peppermint on the stomach. It's a way to distract from the nausea. So trying that. And then there are over-the-counter prescription medications or things that you can be prescribed. But again, some of these can affect your heart rhythm. So it's really good to at least run these by your family doctor or your cardiologist. Next slide. And kind of one of the last topics I did want to touch upon is that mental health is so important for patients and their caregivers. What you're going through is really tough. It's a change of lifestyle, and none of you probably anticipated this happening. And as caregivers, it can be really hard and exhausting. So for my caregivers out there, I just want to express thank you for all you do. And you work so hard. And make sure that you do take in some self-care, and whatever that looks like for you, whether it's getting a coffee, going for a walk. I give you permission to take care of yourself, because if you're not taking care of yourself, how can you take care of your loved one? It's important to talk to your cardiologist or your family doctor or your palliative care doctor for getting help. It's okay to ask for help. So things like personal support workers or nursing care. I highly recommend psychotherapy if you can afford it. medications. So there's lots of antidepressants, many new ones out there that are quite wonderful. And I will say, and I don't know, Dr. Steinberg, if you have this at Mount Sinai Hospital. So if a patient is part of the TGH palliative care team, we actually have a caregivers clinic here as well that's run by our social worker. So I don't know if Mount Sinai has something similar, but the caregivers clinic is just run by a social worker. A lot of it is group meetings and just kind of meeting other people that are going through this. I think that might be my last slide.
Thank you so much, Dr. Lofsky. That was a terrific review of some of the more common symptoms. So I think I'm going to turn it over now to Anne to take us through some of the questions that have been asked when you registered for the event, and we will do our best to answer them. And of course, if there's, I also want to say, if there's anybody, on the webinar who feels like they have additional information, that would be welcome as well. And then if you have questions from what you've heard so far, or if you've had an opportunity to look at the booklet and you have questions, please put them into the chat and we will work our way through as many of those as possible. Thank you, Anne. Take it away.
Yeah, no problem. So thank you. So thank you to the three of you and it's interesting, even as, Kayla, you're talking through solutions, I was thinking back to some of the things that Aaron had suggestions. So it's really nice how you've built on kind of each other and kind of provided between the three of you really kind of rich perspectives. So what I would suggest we do is if you could go to the next slide. So Purva, who's our colleague from the Ted Rogers Center, is womaning the slides. So what I would suggest is let's put up the question and we'll just kind of take a look. And what I would suggest is, as we answer, Purva, if you don't mind, just not showing, the question the whole time and letting our speakers and our folks attending see each other. So the first one is focused on nutritional advice. You did speak to some of the questions. Aaron gave some suggestions of his own, but any other kind of comments that you'd like to provide in terms of nutritional advice as folks manage their heart failure?
I think there's a lot of opportunity for dietitians as well. I know many of the heart failure programs have a dietitian associated with their program. And so, myself, I will not by any means say that I'm an expert in this area. So I think having a dietitian on board, even just for one session, is really great. I think at the end of the day, I recognize how hard it is to monitor your salt intake, but that is one of the key things that you can do that will help with symptoms as well. But I do think advocating for yourself, and that's really important. I want to get that message across to you, is like advocate for yourself. Like if there's something you want, like ask. It might not be offered, but that doesn't mean that doesn't exist. So definitely ask for a dietitian if that's like one of your concerns.
Yeah, and I would suggest when grocery shopping, just get used to reading labels and understanding the food labels, understanding daily percent values and, saturated fats, you'll find sodium on there. So yeah, just get familiar with some of the things there and the measurements, and that'll help determine your grocery choices as well.
It's a whole new level of expertise between reading your prescriptions and reading your nutrition labels.
Yeah, learn, right? Learn.
Yeah. I'll put in the chat too the link to this section on nutrition from the Heart Health that talks in detail and was all done by the dietitian in the Heart Function program. Purva, can you put up the next question for us, please? So, this is kind of a great question. So if somebody lives alone, what are sort of some of the supports arrangements that can be put in place for that person?
Well, I can start. I think everything really applies, but I would it depends. All these answers are going to, depends how sick somebody is. But home care services, I think that would be the thing that jumps to mind first off is, are they connected to home care? So do they have somebody visiting them who has some ability to help with what's happening. So whether that means a personal support worker, do they need help with bathing or showering? That's a reason that home care will send in a personal support worker who can help out a couple of times a week. So making sure that you've got, if they need that kind of help, then making sure that that's accessible. And you can ask, I would say probably more a primary care physician would be a good person to refer you to home care. I actually believe, I could be wrong, but I think you can self-refer to home care, actually. I don't even think you need a physician to do that home care referral, but I'm not positive. So that would be one thing if somebody's living alone. And then again, something that Erin said is, make sure that that person has a connection with who may, the person who is going to be supporting them, either as their substitute decision maker, their power of attorney, a contact, a friend, somebody who's I would say in the communication loop with that person's clinicians. So if they're living alone, even if somebody isn't living alone, but make sure that there's another person or a few people who are in the connection as well as for that person. That's where I would start with that.
Any other tips, especially if you're living alone with advanced heart failure? Erin or Kayla?
I think I just echo a lot of what Dr. Steinberg said, which is, there are resources out there. There are things like personal support workers, nursing support in the community. I think trying to join Facebook groups and just also getting community involvement is really important, because a lot of this can feel really isolating. And so, if you don't have an internet, that's then, the other people that you can touch base with are like volunteer community outreach programs. So there's definitely resources out there. Having a social worker or case coordinator management on your case is really important. And again, this can usually be arranged by either the cardiologist or the family doctor. If you're part of one of mine or Dr. Steinberg's clinics, we can also help arrange that.
I have a question for you, Erin, that just popped up in the chat that I think is kind of interesting. So it asks, like, what if your friends and family have difficulty understanding, that what you're going through is grave? So you look healthy. If I think about you, you're young, right? How do you, some advice on kind of how to help others understand what you're going through?
Well, I think the booklet is a good resource to kind of explain the symptoms. So I would direct them there first, but then I would again go back to the point of repeating, kind of repeating, this is my condition, sometimes I'm gonna feel tired, sometimes I'm gonna feel fatigue, sometimes I'm not gonna want to go out and hang out with you guys, sometimes I'm gonna skip some of our plans, sometimes I need food with low sodium. Keep repeating, keep repeating, keep repeating, and then hopefully your friends and family will kind of get the hint. You're like, why does this guy keep asking for no salt? Then eventually, hopefully, they'll just take over. They're just like, okay, Aaron's coming. Let's make his no salt portion. Let's make sure he has a place to rest. If we're going on a trip or on vacation, let's have maybe 1 day of activity, maybe 1 day of rest for Aaron, or let's just do something and let Aaron rest on 1 day. So you gotta kind of, I think, repetition and kind of hammering it into your friends and your family's heads, about your condition, about your needs. So again, like Dr. Wolofsky said, advocate for yourself. I hope that is okay.
Yeah, that's awesome. Any other thoughts?
Yeah, I guess this is generally the way that I approach kind of how do I help somebody understand something question, which is people will not understand for different reasons. And so it may not be one solution for how to help them understand. So somebody may not understand because they just don't believe you. And the booklet, I think, Erin, what a great idea. You can say, actually, here's some information about what I have. And if you need them to know how serious it is, point to the serious parts of the booklet. It may be, though, that they're not understanding. They're understanding, but they find it too hard to think about or to feel, and that it makes them sad, and they don't want to believe it and talk about it. And so, if you're really struggling with someone, I would say, it looks like for some people it's really that, like, you're doing so great that and you could say, I appreciate I look really great, and isn't that fantastic? But you could say to them, I'm not sure you're necessarily hearing me or understanding when, I tell you how serious this is. And they may be able to say, like, I don't want it to be true. And so you may want to just take it one more step and sort of explore that with them a little bit. But you know what? It's probably one of the hardest things in the world is to get somebody else to understand something that you want them to understand. So at the same time, that may not be possible.
It is the difficulty of listening empathetically and understanding what others are going through, for sure.
Yeah,
Can we
it's a
go back to
challenge.
the questions that were listed? Because I know there's lots of good ones there. So I feel like we talked about number 3. Can we talk a bit about living with uncertainty? So, it's a journey, lots of things happen. Erin, you talked about kind of some of the stages you went through. How do we help people live with cope, and especially preparing physically and mentally, for example, for something like a transplant or an LVAD, an advanced therapy?
Oh, well, my advice would be to start off right at the beginning of the day, ground yourself, make sure you're here, make sure you're present, make sure you're in this world, and that, uh, from one of my previous support groups, there was an analogy that you're on a track kind of, and then you get this diagnosis, and so you move on to a next track, but you're still moving, right? So once you get up in the morning, you get up, you go do your thing, you're already moving. So take it a moment at a time, take it a day at a time, I think. And then as each day passes and you get more confident, you'll see that the days turn into weeks, the weeks turn into months, and so just take each day, ground yourself, take a deep breath and start your day off well. I think is would be a good place to start. I'm sorry, I can't speak to the transplant because I'm not,
No,
I
that's
don't.
great. Leah and Kayla, can you add to that? Because I think this is a central question that I've noticed a couple people have put in comment.
Yeah, I think again, it's hard to come up with really generic or overarching recommendations because everybody's situation is different. I think the thing I would really advocate people do is find someone they can talk to about the uncertainty. Explore what that uncertainty looks like. What can you sit with it a little bit? So some of that is being able to sit feeling safely with the uncertainty, because that uncertainty is actually a very difficult feeling. And in fact, there's studies that show that if somebody is waiting for good or bad news, like if they've gone for a test and they may have a bad diagnosis or it may be fine, that actually the uncertainty part is more uncomfortable than even getting bad news. So I want people to recognize that uncertainty is a difficult place, and that you can talk it through and start to kind of allow yourself to give yourself permission to know it's an uncomfortable place, and learn to sit with that uncertainty so that you aren't trying to get rid of it, because it's not so much getting rid of it, it's learning to adapt to it. So that can take practice and skill, and that can take some work with a social worker or somebody who's got some training in that. So that would be my kind of overarching advice.
I agree. I think the only piece that I'll kind of add is like, there's so much uncertainty. There's a lot of uncertainty. You don't know what medications you're going to be on. You don't know what the big picture is. Try to control some of the things that you can control. And I'm going to put in a plug here for advanced care planning a little bit, because that is something you can control. And so deciding, if you can't make a decision, who do you want that person to be? What would be your limitations? Like, what are the things that you envision for your future versus like things you wouldn't want? Because that kind of stuff you actually can control. And so talking about it out loud and talking about it with someone that you trust can also be quite helpful, because the power of attorney, substitute decision maker that was talked about, talking a little bit about advanced care planning, that actually is within your control and it's something that you can actively do now.
So like taking back some of the certainty because you can kind of direct what happens next. I think we have time for one more question. Purva, do you want to put up, is there any other that were sent ahead of time? Because there's a couple other in the chat. I just want to make sure. We've done all these. Is there any others on the next slide?
No, I don't think so.
Okay, so there's a couple more questions that appeared in the chat. So what I'll do is we'll circle back, and I think we have the emails for everybody, and we'll answer your questions, and we can add them at the end. And one of the questions is like they're a little bit more medically oriented, so we'll just kind of try to answer those offline separately. Purva, do you mind putting up the slides for me? And thank you, Kayla, for answering the difference between acquired and congenital heart failure. All right, so we always like to have some swag. You can't have a webinar without some swag. So just to let you know that we're gonna put your names into a little pulling out of the hat, and so a couple of you will win some swag from the Heart Hub, and we'll let you know by email. So if you wouldn't mind, last slide. So what we're going to do after today is we will edit and post the webinar on the Heart Hub YouTube site, and then what we'll also do is in the transcript we'll add the answers to the questions that we didn't get to, so that just to make sure that everybody who so kindly put a question in the chat will get the answer that they're hoping for, I hope. I think, hopefully you got some insights from our three speakers, and just want to say a huge thanks to the three of you, and love how you played off of each other. It was really rich to hear you offering advice and guidance, and even kind of lived experience and lessons learned as we went along, whether from the physician side or from the patient side. So Kayla, Leah, and Erin, a huge thank you to the three of you. Thanks to everybody for joining. And if anybody who's on the line is Toronto, lives in Toronto, the next thing that we have coming up is the Writing the Heart series, but we're doing it in person for the first time. So it'll be a chance to maybe talk about the uncertainty, maybe a chance to write about your experience. So if anybody would like to join that, we'll also send the link to register. And it's led by Sharon Bray, who's an educator and who is also somebody who lives with heart failure. So those will be coming up a little bit in the spring. So just also want to just say to Kayla, Leah, and Erin, just what beautiful comments have been in the chat as you've been talking throughout, and recognize and thank you for being here today. So we'll close off. Stay well, stay healthy, all the best, and take care.